Well, thank you very much for having me visit virtually with you today and to talk to you. My name is Michael Banata. I'm a neurologist at the University of Miami. If my accent is different, it's because I'm from Cape Town, South Africa originally, but I've now been at the University of Miami for the last 12, 13 years, where I run the ALS Center, which is very much focused on both ALS patient care, community outreach and education, but also we're very heavily invested in research and what we can do to move things forward so that we have more meaningfully effective therapies for our patient community. So I'm honored to be with you, and thank you for the invitation. So what I'd like to do today is talk to you about a topic that's been very near and dear to my heart for many years. And this is the idea of what we've called pre-symptomatic ALS. And I'll explain what I mean about that for those who are not familiar with this. And I want to take you on a journey from how we began to characterize this phase of disease and how this is now leading us into a new and I hope and I think exciting era of the potential for ALS prevention. So before I jump into some of my disclosures, which I must do before I give any talk, I do serve as an investigator at the University of Miami for some industry-sponsored clinical trials, most recently those sponsored by Biogen and Orphazyme. I do some consulting where I advise pharmaceutical companies who are developing clinical trials, both in ALS and myasthenia gravis. I have research funding from the National Institutes of Health and also from the ALS Association and the Muscular Dystrophy Association. And the University of Miami has a provisional patent based on some of my research work. So let me then start with the traditional view of ALS. And we typically think about ALS as a clinical syndrome. And what I mean by that is patients have symptoms. They come to see a physician. The physician might refer them to a neurologist. But this is something that is clinically overt or clinically manifest. And the typical view of this is what I call retrospective, in the sense that symptoms have begun and they've evolved for a period of time before somebody with the disease or suspected to have the disease is seen by a neurologist for a diagnostic evaluation. And the vantage point, the view, is looking backwards, because at this point in time, the neurologist is asking about when symptoms began in the past. And the assumption is before symptoms began, if there was disease, that the disease was pre-symptomatic. And the assumption is that the disease was clinically silent. And we assume that before symptoms began, the disease began. But the truth is, we don't currently have ways to measure or determine when disease began. And so there's an important distinction I've drawn here about the beginning of disease and the beginning of symptoms. And we typically think that the disease process begins before there are symptoms. The analogy there, if that's an unfamiliar concept, is if you have a cold or a COVID infection, you have an infection and the virus is incubating and growing before you have symptoms. Then symptoms appear, but the virus was there beforehand. So we think the same in ALS and neurodegenerative disease, that the disease begins before symptoms appear. One of the things that we need to think about, why is this important, is that we're interested in the timing of therapeutic intervention. When do we treat? And this is the point in the disease trajectory when most patients with ALS are enrolling in a clinical trial. They've had symptoms, there's been a delay till they've developed it, till they've received the diagnosis. Then there's been some time that's passed before there's a trial opportunity and they're enrolled. And my concern, my long-standing concern, is that this may be very late in the course of disease, and maybe treatments that could be helpful are not so helpful because they're giving late in the course of disease. And I think ideally we should be intervening here. We should be intervening sometime from disease onset, even to before diagnosis or very soon after diagnosis. But can we intervene when symptoms begin? Or could we even intervene pre-symptomatically? And so this is the question that we have been studying for some time. So this is what led us to initiate this study called PREFALS, or the Pre-Symptomatic Familial ALS Study, that we initiated back in 2007. So 15, 16 years ago. So PREFALS is a longitudinal natural history and biomarker study. And at the time, we were enrolling carriers of any gene mutation that we know can cause ALS. And we started with this population because the gene mutation carriers were the only population at the time that we knew to be at a significantly elevated risk for ALS. And we were enrolling people with SOD1 mutations, and as genetic discovery proceeded, we've enrolled people with a range of other genetic mutations as well. And we gave people the option of whether or not to learn the results of genetic testing because we wanted to be maximally inclusive, that even people from families with a genetic cause of disease they didn't want to learn, they could enroll and participate and help contribute to science, even if they chose not to learn whether or not they carry a genetic mutation. And the goals of PreFALs were to identify biomarkers of pre-symptomatic disease. And I'll come to the idea of biomarkers, but because there are no signs and symptoms of the disease, the only way to know it's there is through a biomarker, something that we can measure. But very importantly, we wanted to be able to predict when symptomatic or clinically manifest ALS or the clinical syndrome of ALS would emerge. And we needed to do those two things because we were starting to think about how would we prepare for a future of disease prevention trials. Now, the important thing to say about PreFALs, although it stands for pre-symptomatic, very much baked into it is the idea of whether we could predict when disease will develop and to prepare for disease prevention studies. So the pre has many different meanings in PreFALs. So how has this led to an evolution in our thinking? I'm showing here again this cartoon of looking retrospectively from diagnosis and inquiring about symptom onset. But once we start to study people prospectively by enrolling pre-symptomatic or unaffected gene mutation carriers, as opposed to symptom onset, we now call this phenoconversion. Phenoconversion is when people who are at risk for disease and are pre-symptomatic develop clinical manifestations of disease. And importantly, because we're studying it prospectively, we can pick it up much more quickly. There's no longer this long delay until we're able to make a diagnosis. We also have an opportunity when we're studying disease in this way to say, is this period of pre-symptomatic disease, is it really clinically silent? And the truth is what we found is that very often, perhaps always, it's not. That people may go through a period when the disease is clinically silent, but before they develop overt disease, they pass through a phase of what we call prodromal disease. And there are three different types of prodromes that we've recognized. There's what we call mild motor impairment, where there's some subtle, mild, vague, non-specific motor features that don't amount to ALS, but they're also not normal. And in people with some genetic mutations, like the C9orf72 as an example, people may also develop mild cognitive impairment or mild behavioral impairment, what we call MCI or MBI. And I'll come back to these ideas in a little bit. The other very important thing that we've learned is we identified this protein called neurofilament, which is a marker of axons that are dying, nerve cells that are dying. And we could identify this phase of disease where there's axonal degeneration. And importantly, it begins pre-symptomatically and it continues after phenoconversion. And neurofilament levels rise, they continue to rise, and then they plateau. But this was a key observation because this gave us the opportunity to say, who might be developing disease sometime soon? And is that an opportunity for us to think about early or pre-symptomatic therapeutic intervention? So just a quick word about neurofilaments. He has a cartoon of a nerve cell and its axon. And neurofilaments are one of the major structural components of a neuron. Think about it like the nuts and bolts in a bridge. They hold the bridge together. The neurofilaments are what sort of keep an axon whole. And when nerve cells die, as happens in ALS, neurofilaments are released. They get into the spinal fluid. They get into the blood. And we can measure them. I'll just say there are different forms of neurofilaments. There's light, there's medium, there's heavy. We're very focused on the light version for reasons that I probably won't get into today, but happy to come to in the Q&A time if there's time. So this leads me to the ATLAS study, which is one of the topics you'd asked me to talk about. And so the thinking behind ATLAS, the rationale here, as I think I've alluded to, is that often our treatments in ALS are not targeted to the underlying cause of disease. And so one question that we hope to address in the ATLAS trial was to say, could we target the underlying cause of disease when it's known? And in this instance, we're starting with people who carry an SOD1 mutation that puts them at risk for one form of genetic ALS. The other, which I've spent more time talking about, is that treatment is typically delayed. I showed you that because of the lag from symptom onset to diagnosis and from diagnosis to enrollment in a trial. And so the idea here to solve this challenge is, could we intervene pre-symptomatically in those at genetic risk for ALS? So, for example, unaffected SOD1 mutation carriers. And so that thinking is what's led us to the design and now the implementation of the ATLAS study. So just a quick word then about this. So SOD1 mutations have been implicated in about 2% of ALS patients. These are not just found in people with familial ALS. So familial, remember, just means a family history. But we can find mutations in people with a family history, but also in people without. And what happens when there's a mutation in the SOD1 gene is the protein that results from that gene becomes misfolded. And the idea of an SOD1 antisense oligonucleotide, which is a form of a gene therapy, and we're using the product made by Biogen, this drug called tofersen, is if we could lower the levels of that mutant SOD1 protein, might we be able to reduce the toxic and noxious side effects of that misfolded protein? And so tofersen was designed to reduce the accumulation of this SOD1 protein with the hope that this might slow disease progression. And the development of tofersen as a drug until now has very much been in the affected population, in people with ALS who carry an SOD1 mutation. And what we're asking in ATLAS is, could we give this to people with the mutation before they develop disease by way of intervening at a much earlier stage? So let me just quickly review what we know about tofersen from the affected population. So these are the results from the VALOR study. These have been published in the New England Journal of Medicine. And here we're showing the effects of tofersen in the CSF, in the spinal fluid, in lowering the level of the SOD1 protein. And you can see that the people in red who were on the drug as opposed to the placebo in blue, at 6 months, you can see a nice lowering of about 30% of the CSF SOD1 protein. So the drug seems to be doing what we want it to do in the spinal fluid. Importantly, what we see is that the plasma level, the blood level of neurofilament light, which is NFL, you can see in the people on the drug, this also goes down by about 60%, whereas people in the placebo group, it remains stable. Once they go on to open label therapy, so after the double-blind period, you can see the neurofilament levels come down. Now, importantly, in this study, when they looked at the ALS Functional Rating Scale, which was the primary clinical outcome measure of the trial, although there was a little bit of a difference between the two groups, VALOR did not achieve statistical significance on its primary endpoint at 6 months. I will just say that there were some serious neurological events in the study, some serious side effects of the drug in the form of myelitis and inflammation of the spinal cord, an aseptic meningitis and inflammation in the spinal fluid, and a radiculitis and inflammation of nerve roots. And that's important. Although these weren't common, with every drug there's the potential for side effects, and so we need to balance the potential benefits against those potential risks. So let me turn to that second challenge and how we're trying to address this question of delayed initiation of treatment. So the question, if we're taking people with an SOD1 mutation, is when do we treat? We don't know if you carry an SOD1 mutation, will you develop disease when you're 20, or will you develop disease when you're 50, or when you're 70? And since tofersen is given into the spinal fluid every month, and there are some serious side effects associated with it, ideally we want to intervene shortly before disease comes, not 20 or 30 years before disease comes. And that was the key observation we made with neurofilament amongst a subset of people who carry the SOD1 mutation. So what I'm showing you here is the level of neurofilament against time. And time here is time to or from onset of disease. So phenoconversion is this time 0. That's when people whom we're following with mutations develop disease. This blue or light gray shading is the level of neurofilament that we see in the healthy population, people who don't carry an SOD1 mutation. And what you can see in these shaded circles are people who develop an elevation of neurofilament before they develop signs or symptoms of disease, before they phenoconvert. And so this was the opportunity to say, if we follow neurofilament levels and they go up, maybe that's an opportunity to tell us who's going to develop disease soon and to intervene. And so the key observation here was amongst carriers of a subset of SOD1 mutations, those that are highly penetrant, meaning if you have the gene, very likelihood of developing the disease, and people who have rapidly progressive disease. And amongst those people, NFL goes up in the 6 to 12 months before they phenoconvert to clinically manifest disease. So we use that information to build this model of how neurofilament behaves. Importantly, this is in the subset of the SOD1 carriers. And what we were able to say is that if you go above a threshold of what we defined, and we say, what's the false positive rate? So if you go up, what's the likelihood that you don't develop ALS? Very low. And if you don't develop an elevation of neurofilament, the false negative rate, what's the likelihood that you'll develop ALS? It's not nothing, but it's also very low. So neurofilament performed well as a predictor that we could use to guide who we should think about treating in the ATLAS study. So what were the objectives then? In ATLAS, we want to evaluate whether pre-symptomatic initiation of tofersen can delay the emergence of clinically manifest ALS and or slow the decline in function after the emergence of disease. Even if we can't stop it appearing, can we dramatically slow it? And the primary efficacy endpoint is the proportion of people with emergence of clinically manifest ALS within 12 months of randomization. This may get changed to 24 months just based on what we have learned since initiating the study. So this is what the study looks like. We enroll people and we follow them without an intervention, but with monthly neurofilament levels. We send a phlebotomist to the home, they draw their blood, it goes to the lab, we measure their neurofilament levels. If neurofilament levels go up and people are still pre-symptomatic, then they get enrolled in the double-blind randomized phase of the disease where half the people get tofersen, half the people get drug. This is while people are still pre-symptomatic. The primary outcome is that they develop clinically manifest disease, and when or if that happens, they go on to open label drug, meaning there's no longer a placebo, they're receiving the treatment. We also permitted the opportunity in Part D that people might develop clinically manifest disease without neurofilament go up. You'll recall from the previous slide, I show you that rarely that can happen. And if that does, people go on to the open label drug as well. So here's some of the key eligibility criteria, and this is for that Part A, where we're just monitoring people's neurofilament. They have to be at least 18. They have to carry a protocol-defined SOD1 mutation, and I've listed these here. Or they have to have a mutation that an independent committee says is highly penetrant and associated with rapidly progressive disease. The neurofilament levels have to be low at the time of screening, and they have to be pre-symptomatic, meaning they must not yet have developed clinically manifest disease. I did want to say a word before I wrap up about some of the ways in which we're sort of pushing the envelope and challenging existing paradigms here, is that in routine clinical practice, you know, there are many places, I don't know what it's like outside of the US where I practice. It's tough to often get pre-symptomatic genetic testing. Some people are reluctant to do it. Some people are not. But if you do get pre-symptomatic genetic testing, it's very important that this is done in the context of appropriate genetic counseling, that you meet with a genetic counselor or with a neurologist who will discuss with you what are the benefits of learning if you carry a gene, what are the risks of learning if you carry a gene, if you do that in a research study, if you do it in a clinical study, and what are the risks. And I know these less well outside of the US. If, for example, your health insurance company learns that you carry a mutation, how does that affect your ability to get health insurance, life insurance? These are important things to think about and talk about with a counselor or with a neurologist before you get genetic testing. We do that in the ATLAS study, but even if you're doing this outside of a clinical trial like ATLAS, I think that that's important. So we do pre-test counseling. We then do the testing. We do post-test counseling, because you can always back out and say, well, no, I've had testing. I don't want to learn the results. It's always your choice until such time as you learn that. One of the things that we're doing in Atlas that's a little bit different is we're also doing biomarker testing, and we're disclosing the results, right? The biomarker here is neurofilament. Now, this is new. We've not done this before in clinical practice, of saying we're going to test something that changes over time, right? Remember, your genetic status is static. You've had it since you were born. It's not changed. You've always been like that. You will always be like that. But your neurofilament level changes over time. And when it changes, your risk of disease changes. So it's important that we introduced into the study counseling about what it means to learn your neurofilament level. And what we've done is we've put in additional mechanisms for people to request more counseling and to receive more counseling when the neurofilament level changes. Because your risk is low when neurofilament is low, but when it goes up, now your risk becomes higher. And so we felt it was very important to keep the dialogue open and communicate how that risk is evolving to people. And so I guess what I would say is, if you're thinking about participating in Atlas, or if neurofilament testing is available clinically or commercially where you are, talk with your neurologist about that before you have it done, that you understand how you're going to interpret the result, what to make of it, and what is the risk, what does it mean for you, but also what are the risks if your insurance company, for example, finds out about it. So just things to think about, and some sort of cautionary words as you embark on this. So let me summarize then. I think that the study of pre-symptomatic people at genetic risk for ALS has had a few it's changed our view of the disease in several ways. Firstly, it's yielded this first biomarker, neurofilament light, of pre-symptomatic disease. It's also enabled us to discover this prodromal clinical syndrome of mild motor impairment, or MMI, as the first clinical marker of prodromal disease. And I've not had too much time to talk about that today, but I think that that has relevance, as I've indicated below, to maybe studying pre-symptomatic disease in the sporadic population, in people who don't carry a genetic mutation, and might enable us to think about pre-symptomatic or disease prevention trials in a non-genetic population, but in the future. What this study of pre-symptomatic people at genetic risk for ALS has also done is it's empowered us to design Atlas, which is the first pre-symptomatic clinical trial in a subset of pre-symptomatic people with the SOD1 mutation. And what does the future hold? I think we need to find other biomarkers. I don't think neurofilament is the be-all and the end-all. I think it works well in this particular genetic population, but it may not work as well in other populations. And so we do need to identify other biomarkers. I think we want to better understand this MMI and how this might open up possibilities to think about early intervention in other populations. And then I think to design and initiate early intervention or disease prevention trials in those at risk for other genetic forms, but also non-genetic forms of ALS. And so I'm going to stop there, and I don't know whether the Zoom format will allow it, but hope we'll have an opportunity for some questions and answers. So thank you very much.
Excellent, Michael. Thank you very much. That was excellent. That was really exciting. Actually, this is really different to any other study that we've seen before and that we talked about before. We've been talking with many experts, and some of them, or many of them, actually have mentioned this very important study that can apparently change the landscape of ALS research. And so, first off, a very basic question. Can you tell us a little bit about where we at in terms of the stage and phase of this Atlas study right now, and when can we expect next results?
It's a great question. It's hard to predict. I mean, I think we're well underway. You see that there are different stages. There's part A, which is the natural history study, and we've made excellent progress in enrolling in that. That enrollment is still open. It's not yet closed. We're hoping to complete enrollment this year, but that will very much depend on the speed with which the sites participating in this global study are able to identify and enroll people. So importantly, for your community, that is still open. We have had some people develop elevations in neurofilament, and I'm purposely being a little bit vague because I don't know that all of this information is public. But we've had experience now with people developing a rise in neurofilament and going into the double-blind phase of the study. So that is still very much ongoing as well. And so I think if there are elements of the community that are still interested to participate, they should try to find a center that's actively enrolling. And there is support to be able to travel to a study center, even if it's not in your hometown. So we would encourage people to participate. When will we get results? When we originally planned this, we knew this was a longish study. We thought this would take us 6 or 7 years. I think the pandemic slowed us down a little bit. We're probably about 2 years in. So I think it's going to be a couple of years still before we get meaningful results. This is not an easy study. We're breaking new ground, but I think it's going to be a few years still.
But we can say that Atlas is in the phase 3 spectrum or phase 2B.
Well, so I think those are somewhat artificial terms. I think it is in the phase 3 in the sense that we're trying to prove efficacy. Excuse me, there's a good body of evidence on the safety of the drug. We know based on the studies that have been done in the affected population, what the side effect profile looks like. Always, as we're doing studies, we're gathering additional safety data, but we are trying to demonstrate efficacy here. So in that sense, this is a phase 3 study. And what we know from the FDA granting accelerated approval to tofersen in the US for the affected population is the FDA sees Atlas as the additional evidence that will help to support full approval of the drug if we're successful in showing the benefits.
That was basically my next question, because in the meantime, while Atlas was already going for a couple of years, tofersen was finally approved for symptomatic patients. So how is that approval changing things for Atlas? Is this? I would positively think that this will accelerate Atlas, but that's not necessarily the case. How the approval of tofersen changed the work that you are doing with Atlas?
It's interesting. I don't know. I can speculate. I mean, I think that obviously it's enormously exciting that we have this accelerated approval, and hopefully our affected population will get onto the drug as quickly as possible. I think that it elevates the profile, and I think sort of makes the work that we're doing in Atlas that much more urgent. In part because the results will be critical to full approval of the drug, but also in part there really are unanswered questions about when we should start treatment with tofersen. Is it enough to start after diagnosis? Is it enough to start when people first develop symptoms? Or do we have to start pre-symptomatically? Is it enough to start when neurofilament goes up? Or do we have to start even earlier? I think these are critical questions that we need to answer, and our pre-symptomatic population who carry a genetic mutation are asking this. Should I be on tofersen now? The answer is probably not. We're not going to get it approved. I also have a great reluctance to say, without knowing what the risk-benefit profile is, if you're 20 or 30 years away from developing disease, I don't know that it's a good idea to be getting a monthly intrathecal infusion of a drug that has potential side effects. And so now that we have an approved drug, we have to much more clearly define who are the population that stand to benefit from it, so we can get the maximum benefit for that population.
Yeah, and again, you anticipated one of my next questions. I am a family member. I know my brother who passed of ALS. The only thing I know about him is that he didn't have a C9. That's the only thing I know about him. I don't know if he had SOD1. So I'm using myself as an example. But it looks like all family members, even when we only have one case of ALS in the family, it looks like it's not a bad idea to start testing ourselves, at least for SOD1, because this pre-symptomatic treatment might be approved in the future?
It's a very interesting question. I want to try to answer it in two ways. Let me start with sort of the more conservative view. So the first is that our understanding of the genetic causes of ALS are incomplete. Even when there's a family history of ALS, we can identify the genetic cause of ALS in 70% of people, 70. So what that means is in 30% of people with a family history of ALS, we don't know the genetic cause. So genetic testing in general should start with an affected individual. Because if you start with an affected individual and you can find the genetic cause, let's say C9 or SOD, then you know what to test for in a family member and to say, do they carry the same genetic risk? Because if your affected brother carried an SOD1 mutation and you do not carry an SOD1 mutation, then you would not be at a markedly elevated risk for ALS because you don't carry the gene that's in the family. But if we don't know the genetic cause of ALS in your brother and you are negative for SOD1, we don't know what that means, right? You could still be at risk based on some other genetic factor. And so it makes counseling and education and information that much more challenging. So I think as a general principle, I think that genetic testing in a family should proceed from the affected, identifying the cause, and then with the appropriate counseling, offering pre-symptomatic genetic testing to family members. Now, there's the added complexity now that we're doing a clinical trial in a pre-symptomatic population, and let's fast forward to a point in time where we may have the ability to intervene pre-symptomatically. One could make the case that people who have a family history of somebody, even if they don't know the cause, could get tested and learn if they carry an SOD1 mutation to know whether they could enroll in a trial, whether they're at elevated risk. But the counseling there is much more nuanced because a negative result is not very informative at all, right? It doesn't tell you you're not at elevated risk if you don't know the genetic cause in the family. So I think we're getting into shark territory here a little bit. And so I think it requires great caution, great care, lots of thoughtfulness, lots of counseling. I hope that differentiation or that distinction that I'm making makes sense.
Yes, it does. It does. Thank you. So my next question was going to be because this pre-symptomatic approach certainly looks like it's going to change the landscape of not only of ALS research but also of ALS clinical care. If this works, if this treatment, pre-symptomatic treatment, works with this specific method, with the antisense intrathecal intervention, does that mean that the same technique, the same method can be somehow transferred to other gene mutations, or do other gene mutations behave differently? You know what I mean? This would be an explanation for the layman like myself, of course, but this is a question that usually comes up.
So it's a great question. So the short answer is yes. But let me sort of clarify with sort of a longer answer what I mean. So firstly, I do think that different genetic causes of ALS behave differently. And so one size does not fit all. Having said that, I think there are also similarities between and across different genetic forms and non-genetic forms of ALS. And so I think that there are important lessons we can learn, say, from SOD1 that will also apply to other forms of ALS. I think the big principle that we get to learn from this approach, and at some level, this may sound sort of obvious and banal, I've always thought that the earlier we treat, the more likely we are to be successful, right? Think about a cancer. Think about a skin cancer, a melanoma. If you intervene when it's just localized to the skin, you can cut it out and it's curative. If you wait till that metastasizes to the lungs, to the brain, cutting it out of the skin is not going to make a jot of difference because the cancer is spread. I think neurodegenerative disease is the same, in the sense that the earlier we treat, the more likely we are to be successful. But how early? And of course, how early depends not just on what we can detect and when we can detect it, but what's the risk benefit of the treatment that we're using. So I think one of the things we'll learn from Atlas is, what is the optimal time to treat? Because we're going to get a look at, given that design of part A, B, C, and D, in VALOR, the affected study, we learned what the benefits are when you treat 8 months into disease. That was how long people had symptoms for before they were enrolled. From people who go into part C and D in Atlas, we're going to learn, what do they look like if they get treated at the time of phenoconversion. That's about 8 months earlier. We're also going to learn what happens if you intervene even earlier, before there's symptoms, when neurofilament goes up. And what's the incremental value of intervening earlier and earlier. And we'll also learn neurofilament is a marker of disease. The axons are dying. If we intervene at that point, is that enough? Can we stop the disease in its tracks? Or is that also too late? We can dramatically slow it, but we can't stop it. And we need to intervene based on another biomarker even earlier. So all of these sorts of things, I think, are going to be critical to our understanding of what's the optimal timing of disease, that as we have other therapies that come over the horizon for C9, for TDP, for VAPB, for non-genetic forms of ALS, that are going to change how we think about what are our trial eligibility criteria? How do we identify people earlier? How do we enroll them earlier? We're going to have a whole set of new challenges as this landscape shifts, but I think it's going to point us in a new direction.
Absolutely. Finally, besides VALOR, we've been learning about your work with VALOR, but VALOR aside, what else are you working on that you can share with us?
Oh, lots of things. So PreFALS continues. I think PreFALS has been one of our flagship studies for many years, and it's taught us a lot. And I think it has the potential to help us understand, help us discover other biomarkers that I think are going to be relevant to thinking about early intervention studies in other genetic forms of ALS. It's also raised this idea of this MMI, this mild motor impairment. And what we want to start doing is we want to try to study MMI in the non-genetic population and to see whether that can help us address this problem of this long diagnostic delay. I don't know what it's like in Argentina, but in the US, from symptom onset to diagnosis, there's typically a delay of about 12 months. And that's been resistant to all efforts to diagnose it earlier. My hope is that if we can get MMI recognized as a clinical entity, we get physicians, neurologists thinking about it, a little bit like MCI, mild cognitive impairment in Alzheimer's disease. Can we use this as a tool to think about earlier diagnosis? And as a result of that earlier diagnosis, earlier enrollment in multidisciplinary clinics, earlier involvement in clinical trials. And so we want to really try to push forward this agenda of whether studying these sorts of prodromal states, perhaps combining them with biomarkers, can help us address this challenge of this long diagnostic delay. So I think in parallel with the clinical trials, the therapy development, it's a lot of biomarker work. And it's challenging some of these existing paradigms to sort of introduce this idea of these prodromal states, and how can we use those as another sort of tool to enable us to study pre-symptomatic disease.
Great. And I think in my previous question, I said VALOR instead of Atlas. I mixed up the names. I think I did that. Okay, I'm sorry for that. So in the last few months, speaking of changing the landscape, in the last few months, besides tofersen, we also had the approval of another drug called AMX0035. And so as a researcher like yourself, how are you experiencing these new developments and these new approvals?
It's a tough question. You know how to ask the difficult questions. So I have to confess, I've been a little bit skeptical of the phase 2 data that have been published for Amylyx. I think they're interesting. They show promise, but the effects are, at least based on the data we know, they're modest. And I think a phase 3 study is needed to really know, is there an effect? Is there a benefit? How modest is that effect? What's the nature of the effect? Are there subgroups of patients who stand to benefit the most? I'll be at the front of the line saying we need more effective treatments for our patients, but there's an emphasis there on effective. What we don't want is approval of a slew of drugs where benefit is questionable, because the landscape will quickly become very complicated, where we've got 2, 3, 4, 6, 10 drugs, and patients will say, which should I be on? I can't be on them all. Which should I get approval for? We need to approve things that really work. And so I think I'm very eager to see the results of the phase 3 study that I hope will come out later this year or early next year to really help inform what we know about the benefits or not of this drug.
And which other studies look promising to you right now?
It's a great question.
It's also difficult.
It's also difficult. It's always difficult because, there's hope in research, but I also don't want false hope. I think studies that are predicated upon a better understanding of the biology of ALS, that are employing biomarkers that will help us learn from a trial, even if the study is negative, that we can learn something that makes the next trial better. I think for the longest time, we've done trials without an ability, when they don't show a benefit, to know whether this was a worthwhile path, but we didn't do it right, or it's not a worthwhile path. We have to learn. And I think integration of biomarkers into studies is critically important for us to learn. And I think we have to keep learning from the past. I do worry that the pendulum has shifted. We've swung from doing long trials, 18 months, a year, to doing 6-month trials. One of the things I think we might have learned from Valor is that 6 months may be too short. Perhaps if Valor had been a 9 or a 12-month study, maybe we would have seen a benefit on the primary outcome. Of course, it's easy in hindsight to say that. So I'm not being critical, but I'm wanting us to learn that even when we're targeting the primary cause of disease, it takes time for neurofilament to come down, for the clinical benefits to be seen. And I think that we might need to rethink a little bit how we design some of our studies to make sure that we are maximally learning from what we've learned in the past. And I'm purposely giving you a generic answer because I think the hope and the answer lies in those more general principles about how we approach trial design.
Good, understood. Last question. At the beginning of your presentation, you mentioned that you are from South Africa, and most of our audience today is going to be from Latin America. So what would be your message for those patients and families that are outside the countries that are usually in the front line of ALS research and ALS clinical trials? What would be your message for all of them? And because many of them, they will love to participate in clinical trials, but most of the times it's really difficult to do that because of distance, because of cost, and because many other factors.
I think it's an enormously challenging issue, and it's not fair to ask me that as the last question before we wrap up. I'm teasing you. No, it's a challenge. I think that the first step is that we as a global community are, but still need to be even more aware of how there isn't sort of equitable access to research studies, to clinical trials across the world. Some of the things we've done through the NIH consortium that we run, this thing called the CREATE Consortium, is we've reached out. We now have a site participating in South Africa. I had contacts there. We're trying to help build capacity for people to participate in research, to bring opportunities. And so one strategy, I think, is to keep building infrastructure and to partner with established centers elsewhere in the US, in Europe, to become potentially satellites in those studies. I think that's one strategy. Another is, and maybe you can educate me here, is I think we need to see in Latin America more growth of multidisciplinary clinics where people can get the sort of quality care that they need, because those are going to be the natural homes for clinical trials to come. I think it's hard to sort of run before one walks. I think it's hard to set up a trial center when you haven't begun to build the infrastructure for that care. And so I think the model that's been successful in the US is building those clinical centers. And I know that takes resources, and that's the challenge. And then I think the trial opportunities come. I think also what we should all be trying to do is to create opportunities, although they differ, for people to participate in studies remotely, whether those are registry studies, questionnaire-based studies, other things, right? All of those are opportunities for people, even if they're not interventional studies, to contribute to the research mission. But my sense is that our ALS patient community is incredibly altruistic. It's not just that they're participating for themselves, they're thinking about the next patient, the next family member. And I think we need to find ways to broaden our reach for all ALS studies, and hope that those other opportunities for the interventional studies will come quickly. So I guess the message is make sure your voice continues to be heard, continue to reach out and partner. Education is, and knowledge is power. Make your presence felt. And hopefully this landscape continues to shift in ways that I think it's begun to, but not at the pace that I think is necessary.
Absolutely, and thank you for that. And yes, we are working on that. It is an urgent need here in Latin America to have ALS specialized centers, not only neurological centers, but ALS specialized centers. And we are working on that. So thank you.
Let me just say one last thing to say, we're in Miami. We're about as close as we can get to Latin America. If we can help, if we can partner, encourage people to reach out, and if there are ways that we can help, we're more than happy to.
Also good to know. Thank you. Thank you very much. Okay, I think we can close now. So again, thank you so much, Dr. Benatar, for sharing all this development, all these results, and how things are going for the Atlas study. It's definitely very exciting. It's definitely very different from any other trial we've seen before. So we are looking forward to hearing more about this trial. And we're looking forward to meeting you soon, probably in Basel, Switzerland. I don't know. Yeah, you're going to be there?
Yep, I'll be there. I'll see you soon.
Okay, we'll be there too. Okay, see you soon. So thank you so much, Dr. Benatar. Thank you for sharing this presentation with us and answering our questions. And thank you for working on ALS every day of your life. We need people like you and many other experts, many other good experts that we've been talking to in the last years. ALS research looks much more exciting and much more promising than some years ago. So congratulations on your work, and once again, thank you for speaking to our Spanish-speaking community.
It's my great pleasure. Thank you for having me.
Thank you, Dr. Benatar. Bye-bye.
Bye.